Megan Douglas. I am on faculty here at Morehouse School of Medicine in the Department of Community Health and Preventive Medicine, and also the Director of Health Policy for the National Center for Primary Care here at Morehouse School of Medicine. And I guess I can give my disclaimer here too. I am an attorney by training, but I am not providing legal advice during this presentation. I wanted to introduce the audience who is not aware of the National Center for Primary Care. We are located here at Morehouse School of Medicine and do have a number of different programs, some focusing on building capacity within primary care systems to treat addiction and substance use disorders. We are also home to the Georgia High Tech, which has assisted providers across Georgia adopt electronic health records and health information exchanges, and we also have a practice-based research network of primary care associations and community health centers across the Southeast region. And I also wanted to take this opportunity to introduce a new project that we are working on, examining health IT adoption by primary care clinicians. This is a project funded by the United Health Foundation, and we are examining this health IT adoption in 4 states. Georgia, North Carolina, Kentucky, and Tennessee. Will be conducting focus groups and an electronic survey to assess what types of technology is being adopted, how primary care clinicians are using the technology, and then barriers and facilitators to adoption. We will also be comparing the state-specific landscapes and practice landscapes to identify factors that have been either positive or negative in assisting primary care practices to adopt. So I'm hoping that in the next few months you'll see some information about this survey, and primary care clinicians who are on this webinar, we would love to have you participate. So this is where the presentation is not providing legal advice, but I did want to talk through some of the questions that people may be having as they're preparing to practice telemedicine in Georgia. And some of those questions, especially looking from the policy perspective, are who will you serve, and thinking about that from what type of payer or payer mix you may be interested in serving. Who will you bill? So with the same idea in mind. And as you will see this as this presentation proceeds, these questions are relevant to which types of Georgia policies and laws you'll want to be aware of. Thinking about whether you will be the distant site or the originating site or both, and who you will partner with. In other words, who would be the distant or originating site that you would be working with. So in order to answer some of those questions, it's really important to understand the Georgia telemedicine policy landscape. So in the next few minutes for this presentation, we'll talk a little bit about the Georgia Telehealth Act and other related laws. This is really an exciting time in Georgia, the 2019 legislative session. We saw a number of different bills pass that are going to, I think, advance the use of telemedicine in Georgia. We'll also talk a little bit about the Georgia Composite Medical Board. They regulate the practice of medicine in Georgia, so rules and regulations from the Georgia Composite Medical Board apply regardless of what type of payer you may be working with. And then Georgia Medicaid, they have a number of telemedicine-specific rules and regulations in the provider manual. And then I will not be talking about Medicare today, since I will be talking about Georgia-specific policies, but Medicare also has its own set of unique rules relevant to whether providers can bill Medicare for telemedicine services. So just starting with the Georgia Telemedicine Act, Georgia was actually relatively progressive in advancing telemedicine. We passed the Georgia Telemedicine Act in 2005, and this law defined telemedicine and also required insurance parity, so required private payers to pay for covered services that they would otherwise cover if they were delivered via telemedicine. In between, since 2005, we have seen a rapid adoption of telemedicine across the state, and soon after that law was passed, private payers, there was a a slow transition to get all of the different payers on board for paying for services appropriately, but it does sound like a lot of that insurance parity and payer parity is coming to fruition more. But then in 2019, the Georgia Telemedicine Act was amended and is now called the Georgia Telehealth Act, so it is much broader than simply telemedicine. It becomes effective on January 1st, 2020, and it did redefine telehealth and telemedicine. So the law before this expansion had a very narrow definition of telemedicine, but now the law includes definitions for remote patient monitoring and store and forward, and it defines distant and originating sites, which the law did not do in the past. In addition to the payer parity law or parity mandate that was in the original bill, this law also specifies that that reasonable compensation is required. So what was happening was that the originating sites were not getting compensation from payers, at least not on a systematic basis. So this law would require that that reasonable compensation be made for both the distant and originating sites. And then we also, in the 2019 session, had the Georgia Medical Practice Act, which authorized the Georgia Composite Medical Board to issue telemedicine licenses to physicians licensed in other states. So some of the issue with expanding telemedicine within Georgia is that we already have a shortage of healthcare providers within the state. So identifying providers outside of the state who could see patients within Georgia is one of the issues that this law was meant to address. We also have other issues, even with providers and matching primary languages with the patients. There have been examples of needing to work with providers in other states that may speak the same language as an individual patient here in Georgia, and the prior law was preventing some of that being able to happen. And then we also had in the 2019 session the Interstate Medical Licensure Compact. So this allows for expedited licensure in Georgia for a physician that's licensed in a member state. Now this compact may have much broader implications than just for telemedicine, but this trend in adopting the compact has aligned a lot with providing telemedicine services. So this is a compact that I'm not sure, I can't remember how many states are now a part of it, but it's been rapidly expanding across the nation. And for states that are, whose legislatures have agreed to join this compact, it expedites that licensure process across those states that have recognized this compact or joined it. So in addition to the state laws or state statutes that I just went through, we also have the Composite Medical Board who regulates the practice of medicine. They do have a telemedicine-specific rule, a couple of telemedicine-specific rules. The first one is this rule section 363.07, and it requires that a Georgia license in order to perform telemedicine services. And then it also has a pretty specific definition about the examination requirement or how the provider sees the patient. So, and this is where you see a lot of variation across states, is how they regulate and determine the level of the standard that providers have to use in order to make sure, and this is more for patient safety, to make sure that the provider is able to provide appropriate care. So for Georgia's rule, the provider must have either personally seen and examined the patient. They may be providing care at the request of another provider who has personally seen and examined the patient, or they may be able to examine the patient using technology or peripherals that are equal or superior to the in-person examination. So making sure that those boxes are checked is really important for providing telemedicine services. And then there is also a regulation for telemental health. It establishes the minimum standards for delivery. It goes pretty in-depth on the training that is required for both the person that may be presenting the patient and also the provider at the distance site. So anyone considering telemental health or telepsychiatry, I definitely suggest that you take a look at that rule. And then just briefly, we'll talk a little bit about some of the Medicaid guidance. So the Medicaid program did put out new guidance for telemedicine July 1st of this year. It is available in the GAMIS portal, which I have the link here, and then at the end of my slide set, I have the full link in case what you receive you can't just click on. There are a number of technical requirements, so what parameters for internet connection, HIPAA, compliance, and some other technical requirements are included in the Medicaid manual. And just to highlight, there is no payment. Medicaid restricts payment to real-time services, so there is no payment for store and forward or asynchronous services. Medicaid, the manual lists the types of distant site providers, which this list has expanded over time. So these are the types of providers on the left side of the screen that can provide telemedicine services. And then it also includes a list of originating sites. As you see, there is no home for an originating site. So a patient does have to be presented by someone at a place listed as an originating site. And that's been an area of a lot of conversation and discussion, especially as things like at-home monitoring and the convenience factor of patients being able to be at home for telemedicine. But Medicaid, Georgia Medicaid is not covering services like that at this point. Just really briefly, some of the billing information. The GT modifier is still required for Georgia Medicaid. I do think that there are some changes happening with the modifier codes in the Medicare program, but as of now, the GT modifier indicates that the service indicates the distant site service was provided, and the GQ modifier is the originating site. And currently, Georgia Medicaid will pay $20.52 to the originating site as the originating site fee, and indicated by the Q3014 code. And there are different requirements for hospitals billing for the facility fee that are included in the manual. And then coverage requirements. Referring and consulting providers have to be enrolled in the Georgia Medicaid program. There are some pretty specific requirements around written consent that patients have to provide prior to rendering the service. And then the referring provider must be the patient's attending or provider in charge of their care. And then documentation has to be recorded by both the originating and the distant site. And then, again, there are some telemedicine-specific technology requirements with regard to HIPAA compliant. The manual does specifically say that Skype and a number of other platforms that are pretty common on an everyday basis are not appropriate for telemedicine and will not be covered. Okay.